This conference will now be recorded.
Anyway, I usually do the second Tuesday of the month, and it's my pleasure to do this. Um, I'm doing it from my home in Maui, Hawaii, um, and it's a beautiful day, bright sunshine. We miss, as I said last night on the low and intermediate call, we missed the eclipse here, but it's okay. I'd rather have sunshine than I get plenty of night. Um, So a word to thank our sponsors, which we do at every meeting, which include Bayer, Johnson & Johnson, Blue Earth, Telix, Myriad, and Foundation Medicine. I think that's it.
Is Novartis still on our list?
I can't keep track of that. Is
I can't either.
Sumitovant or Novartis or whatever, are they still? No, they're not going anymore.
No,
Right now.
no,
Okay,
no.
excuse me.
Anyway, we are indebted. We are not indebted. That's not the right word. We are appreciative of them because they see the value of your support groups. We are not promoting their products, their medications, their treatments, their scans, or whatever, or their work. But many of us use them and probably have a lot to say about our experience with various interactions with their products. So we are appreciative of them and that they see fit to support us. And it helps us with many of our AnCan activities and webinars and whatever, and keeps us as a vital player in this game. Larry Fish, do you have anything tonight?
Hi, Peter. No, thank you. Not tonight.
Okay. Good enough. Okay. So this is our advanced recurrent prostate cancer group, one of our largest attended groups because there are many of us going through some significant challenges over time and space. Space because some of us actually travel. I get my care in several different places, the West Coast, Minneapolis, as well as here in Hawaii. So what's the show? Have Medicare card, will travel. That's my motto. Anyway, we'll try to keep it light, although I know that in all our cases there's a serious side to them too, and we don't want to overlook that because some of us are up against the wall on some of these issues, treatment not working and so forth and so on. And maybe we'll hear some of that tonight. And certainly we have a lot of compassion and understanding for each other and would be there in a heartbeat if we were across town or whatever from each other. So, and some of us have even traveled longer distances to be there with each other over the years because this is not an easy disease to navigate. And we try to help each other best we can. So let's get going. I'll just start at the top of the list and we'll work our way down. So that's Jeff Marchi. You had something you wanted to start off with tonight.
Yeah, both my Depo-Provera shot and my Lupron shot ran out the 19th of last month, and I started getting about 5 hot flashes a day. And since I was going in for knee replacement and surgery on the 25th, my oncologist said to me, "Well, just don't take Orgovyx. Wait till you get done." Well, I've been on Orgovyx since the 25th, and I've had 1 hot flash, and that was like the first or second day. For some reason, Orgovyx is not giving me the hot flashes that Lupron was giving me. And I'm hopefully it will stay that way, but it's an interesting side effect of switching to Orgovyx.
Interesting. Anybody else have that experience at all?
I think somebody else mentioned it, and that was one reason I thought of doing this.
Yeah, I've had a similar experience. I just started taking Orgovyx the beginning of February. Um, I wasn't on Lupron long term, but I did have a 3-month Lupron shot twice during my course of radiation, and I found the Orgovyx. I'm handling the Orgovyx much better. I never really had hot flashes, Jeff, but I did have a lot of fatigue with the Lupron, and I find much less of that with the Orgovyx.
Yeah, I used to get 10 to 15 hot flashes a day till I started taking Depo-Provera, but I don't need that anymore, which is great too.
That's great. That's great.
Yeah, and I didn't have
Interesting.
any hot flashes on the Orgovyx either. I didn't take the Lupron at all, but on the Orgovyx there really were virtually no side effects for me. Wow, other than the sexual side effects.
Well, this is an interesting discussion. I mean, I don't recall hearing this at all, but I know that it's becoming more and more popular, Orgovyx, and so it's good to hear that. I mean, they probably because it's anecdotal. I don't know if medically I mean, they can't put this on their thing saying you won't experience side effect. I mean, hot flashes if you take Orgovyx. They probably can't put that on the label. But it's interesting anecdotal information that could be very useful to a lot of people down the road. Yeah.
Again, I think it's very much how each of these drugs impact you, because I think there are people taking Orgovyx who suffer from hot flashes and others who do not. It's kind of weird. Maybe Len or Dr. John or Dr. Jeff could say something about this, but um, if it's cutting off the testosterone, which it does, my understanding was it was the lack of testosterone that was generating the hot flashes. So I just wonder why, if you cut it off with one drug, you get hot flashes, but if you cut it off with a different drug, you don't get hot flashes, because it's not about the drug, it's about the effect that that drug is having. Any thoughts from the Brains Trust here?
I think that I remember something about hot flashes not being from the lowered testosterone, but being from a different hormone, probably in the
Uh-huh.
same metabolic pathway, that is also depleted from ADT. I don't know why that should make any difference between an agonist and antagonist, but I have a vague memory of reading something about that. There's a different mechanism for hot flashes than there are for most of our other side effects.
John, I thought it was estrogen driven.
Yeah, yeah.
It's a depletion of estrogen usually causes hot flashes, not the testosterone.
Okay.
Yeah.
But
That's why when you're on darolutamide alone, like David, I think you don't get hot flashes because I think it doesn't. I think it just doesn't block that level of like ADT does.
Right.
You
And
know
we,
what I
we
think
all have individual body chemistry too. I mean, I was on and off Lupron for years, and I never had hot flash issues. I mean, once in a while I could feel something, a little bit going on, but nothing worth reporting or dealing with. It was pretty mild if it was. Um, so, I mean, some of our body chemistry relating to our hormonal levels and stuff probably is pretty specific to us, as Rick just said.
but
You know, I
Might
think
be
I remember
hereditary.
that. I think I remember that where I read that might have been Dr. Wassersuck's book. Has anybody got that within arm's reach of where they're sitting right now? You could look at the hot flash section and see if there's any explanation The edition that I have was written before Orgovyx even existed, but the
Well,
mechanism of action.
I looked up Orgovyx, did a search on it, and they did list hot flashes as one of the side effects.
Yeah, they would have to.
Frank Fabish, you've got your hand up.
You're mute. You're
Nothing
mute.
yet.
From my experience, while I was on having chemo in 2021, I switched over to Orgovyx and have been on it since. Then after my chemo, I switched, I added enzalutamide and started having hot flashes. Then I was switched because of the problems with enzalutamide. I switched over to darolutamide in place of enzalutamide, and the hot flashes continued. I was on darolutamide with Orgovyx up until my doc switched me to 6 infusions with Pluvicto. And he took me off darolutamide. And since then, without being on darolutamide, just the Orgovyx and the first treatment of Pluvicto, I can't remember the last time I had a hot flash.
Well,
So
this is good information.
my question to the docs here, to John and Jack and Jeff, the J's. That's funny. The doctors all, their names all start with J. The doctors on this call must be something.
It's a good letter.
It's a good letter. Okay. So my question to them is that in the way that an antagonist works, isn't it going to suppress both estrogen and testosterone, and not just one, not just the testosterone?
Yes, absolutely.
Well, let's think through this. LHRH is secreted by the hypothalamus, right, and taken up by the pituitary. It's blocked probably at that level by Orgovyx, right? Is LHRH the same drug that stimulates the pituitary to invoke estrogens, FSH, as well as LH? Is FSH stimulated by LHRH as well as luteinizing hormone?
Both luteinizing and FSH are driven by right. I agree.
Okay.
And they're both
So
blocked the ADT.
And there's something also about the ARPIs when you use them by themselves having a greater chance of gynecomastia, isn't there, than when you combine them to Lupron? Len, do you have any recollection about that?
Yeah, the androgen receptor blockers, when used alone, are more likely to cause gynecomastia, particularly bicalutamide. The others don't seem to generate as much gynecomastia as the older receptor blockers like bicalutamide. But
So
my
they must
understanding
block.
of sorry,
Go ahead, Len. Sorry.
my understanding of the hot flashes from ADT is that testosterone regulates body temperature. And so if you're blocking testosterone, it's going to upset your temperature regulation, thereby causing hot flashes. I don't see why, one ADT drug versus another would make a difference. Maybe it just comes down to individual chemistry, like I think Peter said. But
Maybe we'll have to investigate a little more
yeah,
offline.
Anyway, Jeff, even a decrease in hot flashes, just opening up the subject, you increase the hot topic. That's for sure.
Yeah, that was a quick one, wasn't it?
Right. Okay. Frank Favish. Why don't you go ahead?
I started my first treatment with Pluvicto about 4 weeks ago, and I'm coming up on my second treatment on the 18th of this month. My doc decided that in between the first treatment and the second treatment, he wanted a blood draw to look at the numbers to see if there was any problem that developed. We did that, and the biggest issue that came up that I hadn't seen before, and I haven't had the opportunity to talk to my GU guy, was I had a high reading on the lactate dehydrogenase. And a quick research on my part was that it means that when you have a high number, you have some type of tissue damage, and the damage is usually from disease, infection, or injury. And I was wondering if anybody else had experienced that and could add any other details.
Is this something that's routinely tested in blood tests?
yeah,
Or is this
Yes.
it's part of the
something special?
metabolic panel.
Okay.
I think that LDH is a non-specific enzyme, and it certainly it's almost always elevated in heart. The MDs can back me up on this, in like a heart attack or cardiovascular disease. But yeah, there's also LDH being produced by lesions in the bone marrow,
Liver.
metastases to the bone. There's possibly even liver damage. I'm not sure, but it's kind of non-specific.
And they can usually break it down by, they can analyze the band, like if it's a band that's a cardiac band or a liver band, you can differentiate which it is by doing some kind of a test. I don't know if it's electrophoresis, but I do recall that there's the cardiac band and the liver separately, and you can mistake one for the other if you don't differentiate. And then you can think someone's having a heart attack when they're not, and you don't see it.
Frank, is this something that jumped up all of a sudden, or in previous blood tests, does it show an increase, or is this something that just all of a sudden happened?
I never paid attention to it. It never came up, and all of a sudden, when I took this last blood draw, I was going through the numbers, and as Lynn had said, the metabolic panel, and I saw this as a high reading. It was 244 in the reading, and I marked it down as something to discuss with my GU doc when I went in for my next blood draw.
What is the normal range?
I think if I remember correctly, I checked it. I think the highest level of normal was 190.
Okay.
I think in my lab, it was lower than that. It was something like 130 to 230, some range like that. Does that sound right, Jeff?
Frank, are you able to look up your previous test before the Pluvicto?
Yes, I have that ability.
Well, the one thing I would say to you, Frank, is that with these numbers, usually if it's marginally over, and that which would be that would be considered, but I mean, I don't know for every test, but a lot of times, this has been my experience, they don't really care. It's when it's like 3 times over the top or 4 times over the top, they start getting worried. Dr. Jeff, come on in.
So, had you done any vigorous exercise before you had your blood drawn?
No, I wasn't.
Any alcohol ingestion?
I may have, if I'm lucky, I may have 1 drink a week,
Okay.
but
And
nothing out of the ordinary.
any aspirin use?
No, no aspirin.
Well, a real common cause, beside all those things I just mentioned, is when they draw your blood, if there's a degree of hemolysis when they take your blood, meaning your red cells break apart. It can be a product of a bad venipuncture. They shake the tube, the red cells dissipate, you have the blood drawn, it's very slow to come out. LDH is present in all of our cells, lactic acid dehydrogenase, and just by disrupting your red cells in a test tube, you could elevate your LDH. It doesn't always mean something is bad.
I just went on my chart and my readings up to this last one were in the range of 150 to 180 for as I look back over the last 6 of the draws.
Well, Stu, you have to see what your doctor has to say about it. You said you've got it on the list of things to discuss. I just looked at
Yeah,
my
I
blood
sure
work.
do.
I don't even see it tested in my blood work, so I don't know if it's something special or not. I don't see it
Hey,
on my
Peter,
blood. Yes?
Peter, this is Gaushan. I also had an increased LDH. My previous first time I had it, it was 211 on a scale that went to 230. And then they asked me to check it several months later, and it went to 268. So they told me to get it tested again in a month later, which will be middle to end of April. And they said that there is a lab here in Panama that can actually pinpoint by taking blood tests which organ may or may not be excreting more LDH, if that's the right terminology.
Okay. Okay. So again, it doesn't show up on my lab reports, and I do it every month, but I've never had this to my knowledge. I'll go back in history, but I don't know if this is a normal thing to test for or not. But I'm glad you're on top of it.
Yeah, the only other thought was it associated with the radionuclide infusion? That was my only thought when this popped up.
I'll look it up.
Jim Barnes, do you get tested for this LDH at all?
Yes, I do. And you're going to ask me what my range is, but
Okay.
LDH, my LDH is 194. Was that the question? And the range
No,
is
just whether Frank was asking whether this is included in your labs when you go on things like Pluvicto. That's what made me ask you.
Oh, I'm looking at my results, lab results from last week, so they are testing the LDH.
Interesting. Well, it might be, Frank, that's part of the things they look for in nuclear treatment. I don't know.
Where I am,
It's not listed as
LDH
a side
is
effect.
part of the normal metabolic panel.
Okay. Other than that, are you feeling okay, Frank?
The muscle fatigue has hit me the worst from the Pluvicto, much more so than any time during my last 4 years of treatment.
Okay, and you've got number 2 coming up next week.
Yeah, and number 2 coming up. That and dry mouth were the 2 things that smacked me right inside the head.
Are you doing something for the dry mouth? You're using Biotine toothpaste and mouthwash and so forth.
Yeah, I have water, especially at nighttime. It gets pretty bad, and so I have water beside the bed, and also I have honey and lemon lozenges that I use during the day when my mouth starts to get dry, and that works.
Right. There's a paper that Dr. Bob Grommankin put out about precautionary things to do when you start losing saliva in this kind of treatment, because you want to saliva prevents tooth decay, and in lieu of that, you want to use there's Biotine or some kind of special mouthwash and toothpaste, because you got to keep your mouth really clean, because it can cause tooth decay unknowingly, and you can start losing teeth when you lose saliva. So someone could probably put that in the chat window. There's a paper that Dr. Bob wrote up about that. These are products you can get in the drugstore, or special toothpaste that your dentist can order for you. It would just you want to be alert to this. Don't just think it's dry. I'm gonna just cough more and drink more water. You gotta be a little bit more proactive in this one. Go ahead, Rick.
So in the back of my mind, I remember this lactate measure, this LDH, and I'm just sort of looking it up, and it's been used for a long time as a marker for advanced prostate cancer, especially metastatic castrate-resistant prostate cancer. And I know we've had guys who have watched it pretty carefully over the years. At the same time, I still think that, and this is the discussion to have with Dr. Mortasavi, is, what is high? Because just being above, say, 230 or 240, a little bit above the limit, may not mean a whole heck of a lot. But if it goes to 500, then you have to start worrying, Frank. So I think it doesn't sound like it's that high, but it is definitely a marker for advanced prostate cancer. I mean, when you Google, if you're going to look it up, just put in LDH levels and prostate cancer, and you'll see.
Well, Frank, now that you mentioned the weakness in the muscles or muscle pain, that could very well be the source of your LDH elevation. LDH will definitely be elevated with muscle damage or insult to the muscle tissue.
Yeah, I picked up when I did a little research on it, and it talked about tissue damage, and that was something that came to my mind if this was the cause of the muscle fatigue. But again, to me, that's a question I'm going to hit my doc with, and make sure that he gives me some specific answers.
So here's a paper I just found. Haven't read it. I'm doing a Dr. John on us. Here's a paper I just found, and it's a meta-analysis, so it might be helpful. And I'm just putting it in right now. Prognostic value of LDH in metastatic prostate cancer, a systemic review and meta-analysis. Now, whoever can pull this up and read it quickly and tell us the results, they get a gold star. So hold on a minute. Let me send it to everyone. Right, it's there. Okay, there you go, Frank. So read that and you'll know more than you ever wanted to about lactate dehydrogenase.
Okay. Well, thanks for bringing this to our attention. Something to look up. And John put in Dr. Bob's paper about taking care of your dental stuff.
Oh, thanks, John.
Yeah. Okay.
Can I just say something real quick, Peter?
Oh yeah, Jim. Sorry, I missed you.
Oh, no,
Sorry.
no worries. My LDH, I just went back through the history. They've been checking my LDH since November of 2020, just about right after I was diagnosed with prostate cancer.
Okay, interesting. I've never seen it on mine. I don't know why. I don't know if I dare ask. They test me for enough stuff. Okay. Chaz Ryan.
Thanks, Peter. I just have a couple quick questions. I'm transitioning between doctors. The medical oncologist that my radiologist referred me to is not a GU specialist. But this Friday, I have my first appointment with Russell Schmulowitz here at University of Chicago. Dr. Badami, the first medical oncologist, however, has set me up with the second tier anti-androgen. And I've just received my abiraterone. Literally, they just delivered it to me yesterday. I guess since I'm seeing Schmulowitz in just a couple days, I'm inclined to hold off starting the abiraterone until I see him the first time. I guess that's one question. And the other is just generally among all you guys, if there's anything I should expect once I do begin taking the abiraterone. I am also on Orgovyx. I've been taking that for about 6 weeks now.
Yeah, if it was me, I'd wait a couple of days. I mean, it's not like a deal breaker. I'd wait and start it. Just make sure he's on board with it and doesn't think
right
to do something else. Yeah.
That makes sense to me too.
Okay, thanks. In terms of, I'm sorry. Go ahead, Peter, please.
Everybody seems to really like Schmulowitz. He seems to be a good guy to go to.
Yeah, I'm looking forward to it. I mean, I know generally the side effects of abiraterone, they're kind of all in the same general categories, but is there anything anybody's had experience with when they first started taking it that I should maybe be attuned to?
Keep track of your heart at all. If you have any heart issues or anything like that, it can raise your blood pressure somewhat.
Hey, this is Jim Ward. Can you hear me, Peter?
Yep.
One thing I would flag, and I think someone else on this call has also had this happen, but when I started on abiraterone, my liver enzymes spiked. My AST, my ALT, they spiked for at least one test and maybe into a second test that I can't remember how long it was after that. It was probably 30 days, and then they settled down. But my IGU med onc said, you know, that's not uncommon, and it often subsides, but you know, they still get concerned if it doesn't subside.
Okay. Thanks for that.
Okay, Dr. Jeff?
Yeah, be sure to religiously take your prednisone with the abiraterone. It's very important because you don't want to wind up with ACTH that's going to produce aldosterone and cause you to retain sodium and kick out potassium and get hypokalemic. It happened to me, and I passed out in a restaurant. So I've never missed a dose of prednisone since.
Okay. Fair warning. Thanks.
And you take your prednisone with food and your abiraterone without food.
Without, right.
Don't take them together.
It's a pretty small dose of prednisone, so you're not
Yeah.
going to be climbing the walls particularly.
You know, that raises a good point, Dr. John. You don't necessarily have to take your abiraterone without food. But if you take it with food, you change the dose. Now, some of you may have seen that the Lancet put out a fairly lengthy paper on prostate cancer a couple of days ago, predicting a huge surge worldwide. And a lot of the focus of this paper was how do we bring treatment for advanced prostate cancer to the lower income, lesser developed countries. And one of the things that is suggested is the use of abiraterone with food. And essentially, and I remember this when they first started with abiraterone, but the only reason we take it with food is because Johnson & Johnson could sell more that way. Because you need 4 times the dose, and it's just as effective to take one pill with food, and the trials support that. It's just as effective to take one pill with food as it is to take 4 pills without food. But you sell 4 times as many pills if you take it with food. So, thank God I never had to take abiraterone, although probably if I was diagnosed exactly as I was then, I would be getting it today. But if it were me, I'd be taking one with food. And it's much easier. You don't have to get up an hour before breakfast and do all the other things. So one thing I would suggest that you do with Dr. Schmulowitz, Chaz, is to ask him, does he have a preference whether you take it with or without food? You know, you'd prefer to take it with food because it's just easier on your schedule that way.
Okay, that's a very good point, because they did tell me, 7 a.m. before food, wait an hour before you eat. Right.
Right. So we've got a couple of hands up, and people again, and both of those guys are probably going to talk to. I know at least one of them takes it now with food, but I also know David Muslin was trying to get in before, and he got squashed out, and he's just finished eating. So, David, put your microphone on and tell us what advice you have for Chaz with Dr. S.
He's so easy to talk to. You've heard me say it before. He's just easy to talk to, and he's a collaborator. So he'll want to listen to your opinion if you have an opinion. And I would absolutely. I think it's a great idea to talk to him about the food with the abiraterone.
Okay.
And it'll be interesting what he says. So as soon as you hear next week,
I will. I'll fill you in. And that echoes your remarks about him last week, David. So thanks again for that.
Oh, you're very welcome.
Jim Marshall.
Yes, Chaz. Are you taking the 5 or the 10 of the prednisone?
5.
5, okay.
Yeah.
The thing I did was I started it back in 2017 when it was just out. And I kept track and I wrote kind of like a paper on all of the blood tests I get and everything. I probably have a little bit of overkill in the test, but I get testing every month because it was imperative. After the first month, I was on the 4 pills, it was fine. After the second month, the ALT and the AST started to act up real bad, so I got dropped to 3 pills, and I was good for 5 years until I started the treatment holiday, which I'm on now. So the thing I'll do is to put my email address, okay, in the chat, and I can send you the stuff I happen to document about the way I did it. Okay, exercise and all of that stuff, my entire story.
I appreciate that, Jim. Thanks. That's
Okay.
great.
Dennis
Awesome.
Correa.
Yeah, Chaz, just I've been on that Abby low dose for several years. Just make sure you take it with a low fat. And I believe it's less than 7 grams of fat in the food that you have with it. And otherwise, it'll get carried right through and you won't get the absorption of it.
Oh, okay.
And it's a small meal. I forgot the number of calories, but just as an example, I do it with a bowl of a package of instant oatmeal. And that's what I would do. And right now I've been on a break, so I'm away from everything right at the time. But when I'm taking the drug, that's what I do.
So if I understand you, Dennis, if I get the okay to take it with food, then take it with a very low fat, low calorie diet, meal rather.
Correct. Less than
Okay,
7
great.
grams of fat is considered a low fat meal.
Awesome.
A lot of people drink a glass of 2% milk and take the 1 pill, 250.
Yeah, I try and stay away from dairy actually.
Yeah, there was actually a small study done that came up with that routine of taking 1 Abby with the low fat meal. I don't recall a recollection where it was. I think Len may have turned me on to it initially. If he remembers what it was, what the calorie content was, but it was based on that.
What's 1, Dennis? 250?
Yes.
Yep.
Yeah. Okay.
Okay. And about 30% of us get a high blood pressure reading triggered by abiraterone. So just keep an eye on it. Monitor your blood pressure once in a while, and just hopefully you're not in that 30% range, because then you got to go on blood pressure meds and stuff. So anyway, just keep an eye on it.
And Jim mentioned it before too. I got to start getting more exercise too. That will help fight that and everything else. The worst side effect for me has been the weight gain over the years with the
Lupron.
the other hormone treatments, and I just got to start fighting that.
Yep. Well, it's not fighting. It's just being proactive. It's okay. It'll all work for you. Okay. Very good.
All right. Thank you, everybody. That's some really good stuff.
Okay. Les.
Don't forget to check the chat window, Chaz. There's some stuff in there for you.
Okay. Thanks, Rick.
Les. Go ahead.
Okay. Brief summary. I've been at this for 11 years. I've been doing this and that. Has been keeping things down pretty good until about almost a year ago. I was on darolutamide. Took it down sharply in like 21 days. So it seemed like it worked real good. They also put me on chemo, this docetaxel, and that brought it down a little bit more, but then it started going up. And after that, they did Pluvicto, and that didn't do anything. So they put me on double chemo, this Jevtana, carboplatin, and that hasn't done any good either. So the last PSA I went and did last week, the blood test, PSA was about 60, and apparently there was a lot of activity in the PSMA scan. Doc says marked progression of multifocal PSMA avid metastatic disease since the November one, progressive metastatic disease in the spine, so forth and so forth. It's a little bit specific about where. Anyway, then he's suggesting now discontinuing the darolutamide and Jevtana carboplatin and start on abiraterone or Zytiga. And that's where I am right now. That they're supposedly starting me on abiraterone.
Right.
I've got just learned I've got had tried to get a video consult with Dr. Sartor, and finally got hooked up with him. I'm going to have a video conference with him tomorrow morning. And so I was very interested when people were talking about that abiraterone, because supposedly I'm going to be starting on that now. That's about it.
Okay. Well, Les, we're with you on this. I mean, I mean, a number of us have been through this thing where drugs stop working and this and that, and the doctors really don't have a lot of options left for us. And you've certainly run your course over the last 11 years. It's amazing what you've done. I mean, you're a trooper. Amazing. I mean, you've met challenges that none of us have faced, and we care about you. I think probably some doctors are faced with the option of just rather than just battering you, just giving you some better quality of life, so that it's not totally out of it when things are failing.
Dr. Kwan has been very restrictive on making any predictions of any kind. He always has been. He's always talking with rose-colored glasses, but I pinned him down this time. Said, I know somebody broke your crystal ball, but and then he stopped me and come back in the room and said, well, I give you 6 months. He said, could be more, could be less, but that was his thought, which I was a little surprised he was that blunt, because he's always been very restrictive on making any predictions. I was interested in the abiraterone. I haven't looked at it yet, but I think Len posted something about the different methods of taking Zytiga. I don't know if I haven't looked at it yet, but I thought that was what you were in the process of posting.
Well, Les, I would ask Sartor if he agrees with you starting on abiraterone, and if he does, how long should you stay with that before if you don't see any results?
Yeah.
Because it's just statistically, it's not likely that will help. From historical cases of guys being switched from one uh, uh, second generation hormonal agent to another, particularly going from something like darolutamide to Abby. So what I'm trying to say is, if I were you, I wouldn't waste too much time on Abby if you don't see a response pretty quickly.
Okay. Yeah, I have they sent it already. They prescribed it Friday, and I received it about 7 o'clock this morning. But I haven't taken any yet. But I wanted to talk to Dr. Starter before I started to take it. But I do want to look into more of this different methods of taking it before I start also. Dr. Kwan had commented that he has had patients that have gone that route. Other things too didn't work, but he put them on Zytiga and it did make a difference. So that was why he was trying it. He had seen it before.
Yeah, many of us have been in that situation where, the doctors don't know for sure, but they, if you mix it up, they've gotten some results. And I mean, all of us are a little bit different in how we respond and so forth. Yeah, and you've met with Sartor before, so it's not a first meeting. So he knows you and he has some idea of what you're going through. Let us know, what the results of your meeting tomorrow are with him.
Okay. I have noticed in the past, Dr. Sartor seems to be a little bit prone toward clinical trials than some of the other docs.
Yeah,
so
well,
we'll see what he has to say.
Les, at this point, that's what you need. You need a clinical trial. And Kwan doesn't really stay on top of them. And what I'm concerned about is the politics at Mayo and the politics that exist between Sartor and Kwan are not easy. They say they are because they don't want to get caught out, but I know they're not easy. And so it places the doctors in a very difficult situation. Now, Kwan is out of his depth with where your disease is right now. Yes, it's true that abiraterone can have an impact, but it's probably thought to be maybe 8% of people or less. So it's a very, very low percentage. And if you have followed these groups recently, there are some good trials that are out there. So Dr. Bob, Al Latimer, Mark Finn, who are all well advanced, they're all looking at the ARV 766 trial, but you have to have the right mutation on your androgen receptors. So I don't know when the last time they did a test for you was, but one trial and I would discuss these not with Kwan, I would discuss them with Oliver Sartor, because he's going to know exactly what you're talking about and be very knowledgeable. So ask him about the Arvenus, the ARV 766 trial, and have your most recent genomic testing results in hand. When was the last time you had genomic testing?
Well, they just took the sample again, but they're using what you're not as fond of, that Garden 360, but we haven't gotten the results back yet.
Yeah, well, the problem with the Garden 360, and we just saw it again with Al Latimer, is it doesn't do the job. And you should know, it's no good telling me that I'm not fond of it. It's conveying that message to your doctor and telling them to send it somewhere else. That test should be sent to Tempus or FMI. And why? Because we want to make sure that if you have this androgen receptor mutation, you are then eligible for the trial. We don't do these tests for fun. We do them to find new drugs that may help you. So, if I don't, you say, when did they send that Guardant test off?
It would have been Friday.
And that was Quan that sent that off?
Yes.
Yeah. Well, I don't think Sartor would have done that. And I don't know how to I keep telling you, you've got to pick your quarterback and stay with them, because when you switch from one to the other, it causes issues. And Quan is out of his depth at this point in time. The other trial that he should be talking to you about is the DLL3 trial, which we have some people looking at, which Dr. Sartor again is going to be very familiar with. Misha Beltran is running that trial with also Rahul Agarwal, and Sartor may be involved in that trial. I'll look it up right now and send you a message.
Okay.
But what the reason Dr. Sartor likes the trials is because for gents like you, we don't have the right treatment. As you know, we're taking you back in time to abiraterone. Have you never been on weren't you on abiraterone many years ago?
No, I was not. And they'd asked me about that beforehand.
Okay. But you were on enzalutamide or one of the others, right?
Yeah.
Right. So, they're going back, and time is of the essence, and we need to look at what's coming up. And somebody who knows what's coming up is Dr. Sartor.
Well, he's got an appointment. He's got an appointment on tomorrow.
I understand. I heard that, Peter. I heard it. But the problem is that you've got two doctors who don't see eye to eye. It's the same two doctors situation that we have. I got myself into trouble a couple of weeks ago on this, but it's the same two doctors situation. And you get into trouble. And the only thing we can do in this group is say to people, don't have two doctors. Pick a quarterback and stay with him, and pick the best quarterback. And if you want to stick around, Les, you need to be with Sartor. We did so much to try and get you to go to Sartor. You're with him. And, what does Quan say? Well, let's throw some abiraterone at the wall and see if it sticks. No. Dr. Sartor is one of the best docs in the country to try and figure out where you're going to go. But you need to place yourself in his care, because otherwise he's going to get flack from Quan, and they're in the same institution. And it's a problem. It was a problem when Sartor went over there. He told me. So again, you make the decision, but those are two trials. And I wouldn't, just like with Chaz, I wouldn't go on the abiraterone until see what Dr. Sartor says. One of the reasons for that is if you start that abiraterone, it might exclude you from a trial. So you don't want to take the abiraterone and then find you've got to wait 4 weeks or 6 weeks to get that out your system. Anybody else?
Len had sent me some trial number. I don't remember exactly what. I did look into it, but I don't remember exactly too much about it. Was that
probably
something?
that HPN trial?
I don't know. You gave me the number, which I used to look it up, but I don't remember exactly what it entailed.
But Len, did you see that trial? You say?
Yeah, I'm not sure. I did send Les a link to a trial. I'm not sure if it was a DLL3 or a HPN. What is it? 328. I'll look through my email, see if I can find it.
I'm just checking right now to see if Sartor's on that DLL3 trial. for some strange reason, I did think he was, but and the and I see the HPN. The HPN, that's the trial. That HPN, that's the Harpoon trial for the DLL3 Len that we want him to be discussing. That's exact. Good job. I mean, that's exactly the trial. And let's see, is it Michigan? No, it's not. It's not run. They're not running it at Mayo, but he's going to know. He's certainly going to know about it. He's certainly going to know about it. Where are they running it close to? They're running it in Milwaukee. That would probably, as far as I can tell, that would probably be the closest to you, Les. But and in Detroit, that's going to be further. But yeah, I mean, these are the trials that you've got to discuss with him.
Okay, I will do that. Thank you.
Okay, last words with you. Keep in touch. Thank you for keeping in touch with me and with Len. And yeah, we care about you. And, as I said, you've certainly been through a lot of things ahead of many of us, and things that probably none of us will ever go through. And,
if you have time, you've got 3 questions in the chat, 3 hands up in the chat window on this.
Okay, Eric, go ahead.
Yeah, so I just wanted to ask you, Les, like how do you feel? Like do you feel a change in your health after these diagnoses, or are you feeling the same as far as health wise?
Well, I don't think it's changed very much, but my endurance is 0. But it's been that way for a long time. It has gotten a little bit worse since the last double chemo, but there's not been a dramatic change.
Okay.
Jeff, Dr. Jeff?
Yeah, Les. I've been a physician for almost 50 years. And I want to tell you the number of times I've seen and heard doctors tell patients, you have 3 months to live, you have 6 months to live, things along those lines, and they have been wrong. I've seen situations where the patient who was told by the doctor they had a limited time frame, they outlived the physician. So it's almost inappropriate to do that to somebody, to look into the future and tell you you have 6 months left to live. 2 times in my life, I was written off, and I'm 73 years old and I'm still here. Written off on words of physicians telling me this will never get better, that'll never get better, and they're wrong. When I was a boy, I had polio, and the doctor told me, you're not going to run, you're not going to play. I played high school sports, I played college sports. So take that, don't give up hope because this provider gave you such bad future look. We are often wrong.
Good
So
point.
I don't think he meant it as a definite. In fact, he since I was asking about it, he just make a wild stab at that you may not have anything or too far in the future to look for. But from what you said, when I was first diagnosed over 11 years ago, I was given less than 2 years to live, and the way they were talking, they didn't expect me to finish out that 1 year. I say that was beginning of 2013. So I know what you're saying. They can only go by the statistics that they have, and it's not an absolute.
Right. And as you said, you kind of pushed Quan into a corner to,
Yes,
to
I
get
did.
this out of him. I mean, this wasn't something he was meeting you at the door of your appointments, with this
No,
good
he
news.
has never in the past made any estimate or anything, and I've never asked him. But I'm a little bit of a corner personally right now as to wondering how things may progress. So I was trying to get some idea.
Okay, Frank Fabish.
Just a quick comment, Les. About 6 months ago, my PSA was rising. I was on Orgovyx and darolutamide, and my GU doc said, "Okay, we're going to switch over to abiraterone and prednisone as the second line, but you're going to stay on Orgovyx." I was on that for 4 months, and my PSA continued to rise. And that's when he took me off of it. And then now he started me on the Pluvicto. So my experience with the abiraterone, prednisone, wasn't positive.
Yeah, well, I didn't do very good on Pluvicto. It didn't help me at all.
Right. Yeah.
You know, one thing that just occurred to me, Les, when you speak to Sartor, because there's probably no other docs in the country that are more expert in Pluvicto than Sartor. Maybe a couple that are as expert, like Mike Morris. But if you just had a PSMA scan and you are PSMA avid, at least in part, and it showed up, it's hard for me to understand why the Pluvicto didn't work for you or do a better job. And that's another thing to drill down with and make sure that Dr. Sartor is well aware, which he should be, that you just had another PSMA scan. One question for Dr. Sartor might be, what about one of these trials coming up with a different type of antibody? So there's a trial out there there are trials out there with actinium, which is a different payload, and maybe that what might work. And there are trials out there with different ligands, these monoclonal antibodies that carry the radioactive element into the cancer. And he knows all of them, and he may be able to figure out why it is you didn't respond to the Pluvicto, but he might think that you would respond to another drug, because it's sort of inconsistent to me. Didn't you say you just had a PSMA scan and it showed up a whole bunch of stuff?
Yeah.
And you're sure that was PSMA, right? It wasn't an FDG PET or it wasn't a C11. It wasn't one of Quan's C11 scans.
No, it's the PSMA gallium-68. That's the ones I've been having the
Right.
last 3 or 4. I think 4 of them have been.
Right.
Yeah.
Well, I mean, if you're showing stuff up on that, I don't see why you're not responding. And that's the question. But if anybody can figure that out, anybody in the whole country, maybe even including the Australians, but if anybody can figure it out in this country, it's going to be Sartor as to why you didn't respond if you were PSMA avid. Now, that doesn't mean to say that you still have a bunch of cells that aren't PSMA avid, but we know you have some cells that are PSMA avid because they just showed up in the PSMA scan. So he's the right guy to try and figure out why you didn't respond.
Okay, I can inquire, but remember, he was the one that took me off of Pluvicto. It was his decision that I stop.
Okay. But now go back to him and say, Doc, I'm still PSMA avid. Why the heck isn't the Pluvicto working?
Yeah.
And he's very he's really open to discussion. He loves talking to patients. He's not going to say, I don't want to discuss this.
I've been very comfortable with him, and my wife agreed with that he's very easy to talk to.
Yeah, and this is where we've got to try and challenge him, push him a little bit, and say, why didn't I respond to this? And then come back to him and say, well, okay, I didn't, but do you think I might respond to some of these other trials that we just talked about? The Arvenus, which is worked completely different way to the Pluvicto, or the DLL3, which is another completely different opportunity. But if you want, I can't. Your call is tomorrow morning, right?
Right.
Len, I don't want to put you on the spot, but I do. I mean, would you be willing to help Les out with Sartor tomorrow?
What time is it, Les?
11. I think it's 11:05 Central Time.
So 12:05 my time. I think I can do it. Let me take a look at the calendar.
I mean, Les, I would strongly navigate you to have somebody like Len on the phone if he's willing to do it, because he knows his way around this stuff, and he's fantastic. It's a fantastic resource for you to have at this point with Dr. Sartor.
Yeah, Les, it looks like I can do it. If you want to ask them how I'd be able to join the call.
Okay, I will do that.
Okay.
Great. Thank you,
I
Len.
appreciate that, Len.
Sure.
Yeah.
How's your wife holding up, Les?
Oh, she's doing pretty good. She helps me out with, I have to go to my resident biology professor to understand all the words in these reports.
Yeah. Well, we're with you, Les. I mean, as we all know, I mean, on a physical level, we're challenged sometimes, but on the emotional and mental level, when things start not working and not going the way we think they should or we'd like them to, there's a lot of stress and weird things going on in our heads and our hearts. So we're with you. It's a tough spot.
Okay, thanks, Peter.
Yeah, and thanks, Len, for stepping up on this one.
Sure.
Thanks, Rick, for suggesting that. Yeah, I think in the days ahead we'll see a lot more of that, of helping each other. Okay. Okay, Eric.
Yes, hello. So there's been a little change in my health. So my PSA started to increase. Last PSA was at 6, and I had a PET scan last week, and it showed that the disease is reoccurred or is in the prostate, and um, moved to a few lymph nodes. So my doctor at John Hopkins, Kathy Marshall, said that I'll be a good candidate for this trial, where they give darolutamide plus ADT and a placebo or something like that to study, uh, to do their study. And my question to the group is that I know I heard sometimes throughout being here that you need to have if you have certain treatments first, then you can't have other treatments later. So I'm not that well versed in this. I just want to make sure that, uh, this trial wouldn't prevent me from having any other standard treatment or any treatment in the future. And I have the application number to the trial that somebody asked before. I'll put it in the chat.
Okay. Well, ADT and darolutamide, to my knowledge, is not that unusual a treatment.
Oh, that's the IRB number. That's the IRB number. What we need is the NCT number. Do you see on any of the papers anywhere an NCT number, Eric?
I'm looking. No, I see there's a Bay number. There's a J2399 number.
So here's what I would suggest. Before you start on this, have you obviously did you meet with Dr. Handy Marshall, or was this all on the phone?
So I had, after the PET scan, we just did a phone visit.
Okay, so what I would say is this: before you commit to the trial, or right now, ask Dr. Handy Marshall for the NCT number, because I don't think we can track the IRB number. Those are not usually public record, if I'm not mistaken. And it's going to be something that's going to be available within Hopkins, because it's sort of an internal that's sort of a internal review board. What we need is that NCT number. We'll take a look at the trial. The thing right now is, from what you're saying, is that neither of the two drugs that she wants you to have are trial drugs. They're both publicly available. The issue might be that she might be challenged to give you the darolutamide with the stage of your disease. So by putting you in the trial, it's easier for her to give you the darolutamide. And darolutamide is a drug we like a lot.
Mm-hmm.
That said, in sequence, if you're going to do this in sequence, what we seem to think is that if you get the abiraterone that we've been talking about quite a lot today, along with Orgovyx, both of which you could probably get, and I don't know what type of LHRH drug they want to give you in this trial, it might not be the Orgovyx, which is the pill, then and you can tolerate that's the best thing to start with. I mean, it's pretty much agreed right now for somebody at your level. The trials all seem to say start off with an LHRH drug, and preferably the Orgovyx and abiraterone. And then if the abiraterone doesn't work, or you can't tolerate it, like happened with David Muslin, for example, we switch him to, or no, was David was on ENDS, I think, but other people who have had the abiraterone and they can't tolerate it, we try and switch them to the darolutamide. But there's nothing special per se with either of these two drugs. So what we'd like to see is what this trial is, and we need the NCT number, which is the number that that clinical trials uses, the organization that registers all the clinical trials.
Okay. Okay, I'll
Am I
reach out
making
to her.
sense
Yeah,
as to why?
I'll reach out to her to get the NCT number and ask her about I guess the standard treatment,
Sure.
right? You know, and see what she says.
This is John. I tried to. I went on the Hopkins IRB website and I was unable to penetrate it to the point of finding out what the trial was.
I got the consent. I got the consent form, but that probably won't help you. I could put that in the chat.
Um, well, better than, I mean, if you sent us, you could send it to me and I'll take a look at it. If you send me the consent form, I can look through it and see if I can see the NCT number. But if you just ask her for the NCT number first, before we go through the consent form, let's think about whether this is a good trial for you or not.
Okay.
And we have the brain power in this group to be able to look at this trial and come back and to give you the right discussion points to talk with Dr. Handy Marshall. I mean, she's a great doc, and we like her, and you like her. So, it's a good fit. But sometimes, and this is an issue you might have heard us talk about before, and we have to be really careful with this. These doctors have a conflict of interest that work in academic centers. Just the way that, say, doctors that work in private practice have a conflict of interest because they want to push you into a certain treatment because they make some money. There is an academic conflict of interest, which is putting people in trials which they may not be best suited for. So we won't talk about the academic conflict of interest with Dr. Handy Marshall, but we will with you. And we want to make sure this trial is a good fit for you.
Okay. Yep. I will definitely email. Yeah, I did a quick search for NCT on the consent form and it's not in there. So I'll ask her.
Erica, currently you're not on any treatment at all?
No.
Okay.
Go
ahead.
I think 2 years ago I had like the regional the pelvic region radiation, and as of like within the last 6 months or so, then the PSA started going up and go down a little, go up, and then it's gotten to there. And then we got a PET scan, and then this is what it showed.
So you weren't on any treatment during radiation either? You weren't on any? Okay.
No.
Larry Fish, you've got your hand up for something.
Yeah, I don't know this whole discussion, what Rick is saying about, there's potential conflict of interest with trials, how doctors can push people into trials that they're encouraged to. It brings up to me two questions I'd really want to know, if I were Eric, or if I were told. The first question is like, what's the reason she's suggesting this trial? And maybe the idea, is this a path towards being able to get darolutamide? And the other question is, what phase is this trial? Because maybe it's a phase 1A or a 1B or something. And that's like you don't want to get pushed into any of those. So that's two questions I'd really want to know is,
right.
Of course, the NCT number will help with this, but also just those NCT number, what phase is the trial, and what's the reason you're suggesting this trial? I don't know if she has time to answer. Those are the
So
questions
the
in my
consent
mind.
form says it says it's in phase 3 study.
Oh,
it's
okay.
It's control phase 3 study.
Yeah, so that could be a valuable phase. That could be a valuable trial. It does answer that part.
Yeah, but I absolutely agree with Larry. I mean, we want to know why she thinks this is a trial. I mean, we don't even know if there's a trial drug involved because we do know the LHRH, whatever it is, Orgovyx or Lupron, whatever it is, and the darolutamide, neither of those are in trial. So there's got to be something else that's going on here, and we just want.
I'm sorry, because part of it said in combination, it's like it's a double blind trial where you get darolutamide or a placebo, and a placebo with an ADT.
Well, if that, In which case I would say, no, that you don't want to do it because you don't want the placebo, because right now you want to be getting an LHRH drug, preferably Orgovyx, and you want a second-line anti-androgen, maybe abiraterone, but maybe something else. That's the right treatment. So why even take a chance that you won't get those two drugs? I mean, yes, if you got the Orgovyx and darolutamide, would it be much worse than getting abiraterone? No. Would you feel better? You might feel a little better, but at least we know you're getting the two drugs. What we don't want to see is you just getting LHRH alone and a placebo. That we don't want to see that, and there's no reason for you to get that because both those drugs are available to you. So what this means is they can put you into a trial where you'll get less than standard of care. And whoever designed that trial, they didn't have a patient advocate saying to them, why do you have an arm that's less than standard of care? We found this with Bayer.
Well,
I know which
this is
trial this is. I
this
know
is
it.
a
Len,
this is a Bayer
this is,
healthcare. This is a
yeah,
Bayer.
Len, this is that stupid Bayer trial. We went back to Pooja and we said, you can't do this trial because it's not standard of care. And Pooja came back and said, we've changed it. Do you remember?
Yeah. Uh, but I thought it was a trial where they just wanted to show, was enzalutamide involved at all in this trial?
No, it just is darolutamide to me. So I'll put a little brief
The
description in the
one,
Bayer
chat.
makes darolutamide, so that would be it.
Rick, the one that we challenged Pooja on, I think, was why were they running a trial of darolutamide and enzalutamide, and all they were doing was measuring testosterone levels.
No, there was another one, I think even before that, where they were just giving LHRH and placebo on one side and LHRH and darolutamide on the other. And we said, you can't do that anymore because somebody who's got the diagnosis that Eric has, he's entitled to get a second-line anti-androgen. That's what we know is the treatment. And then Pooja came back and said, well, I passed that through to them and they're going to change it.
Oh, okay.
Well, Eric,
Yeah,
get
Eric,
get the numbers, and then so we can help you. Okay, you got to
Okay.
get more information so we can help you figure this one out. Otherwise,
Okay.
we're just speculating.
Okay.
Okay.
Yep.
But Eric,
Oh, yeah. Go ahead.
whatever it is, don't agree to go into anything that doesn't give you at least LHRH plus a second line anti-androgen as a minimum. Anything that it, of
LHRH.
an LHRH, which is like the Orgovyx that you were on. Remember when you were on the
Yes.
Orgovyx?
Uh-huh.
So it's like the Orgovyx plus another drug, that's the absolute minimum that you'll consider.
Okay.
So you were on it. You were on Orgovyx.
And what? Yeah. Before, after my first, after, yeah, I was on Orgovyx. Yeah, for
Okay.
doing my radiation treatment.
Oh, okay. So you were on a drug during radiation. Okay.
Yeah.
Got it. Okay. Well,
Sorry
yeah.
about that. Yes.
Get back to Rick or any of us and let us know what you come up with when you talk to the doctor for sure.
Yeah,
Okay.
you got my email, right, Eric? You can send it to me, and then I'll bring in the guys if we need them.
Yep. I will send this to you right now.
Okay, man.
Okay, Jim Marshall.
Oh, yes. A different subject.
You're still with us, so you must be
Yes.
doing okay.
I am well as can be expected. The long and the short was 2 stents, turned out not to be 2 stents, had to back out, and it was a triple bypass. And the day after that, I developed hypertension, AFib, and a low red cell count down to 7. So they attacked the hypertension first, and then the AFib second, okay, and the red cell third. So ended up in 4 days in bed, could not get out with all kinds of tubes, monitors, and everything else. And every time you moved, an alarm happened to go off. So ultimately, I happened to walk out of there. But now the after effects, the biggest thing is fluid retention in the legs, which is slowly going down, and it screwed up the sleep clock, and it's still messed up. I can only do about 3 hours at a crack if I can do that. And the big thing is you have to sleep on your back. You can't sleep on your side. You can't use your arms. Try to get out of bed and having your arms locked across your chest. It's interesting to do, but it can be done. So other than that, yep, I survived. So the recommendation is if you get yourself shortness of breath, even though you might blame it on something else, go for a nuclear stress test, because a stent was like nothing. I was in there for a couple hours awake, up the arm, didn't even feel it, looked around, ascertained that he could have inserted the 2 stents, but it turned out he could not. So other than that, I'm just trying to get my clock straightened out and to get some sleep, and then some exercise after that, and to start to recoup. But the good part of it was last month at the first of the month, well, I don't know if this is good. I had been on a treatment holiday for 21 months, and the PSA just started to nudge up. So luckily, I did all of this on a treatment holiday. I have no idea if I had to do the pills, Lupron, how it would be. So other than that, hey, I take it day by day. Okay, and the recoup period is 6 weeks until they say, and with the breastbone might, wait a minute here. The breastbone will be repaired, but it's actually 90 days or so before I'm hopefully back out on the bicycle and exercising and doing good things.
How long do you have to sleep on your back?
Wait a minute here. I'll find that out. I know probably for the 6 weeks, but it may be for the 3 months to make sure it is, because as they say, Jim, if you go home and you start hearing a clicking sound in your breastbone, you'll be back here for another 5 or 6 days to get it fixed. So I am going to stretch that out as long as possible. I don't want to crack it, even though it's wired up. Now, does anybody know offhand, is that once you have, and with the breastbone wired, does that knock out CT scans at all, or MRIs or anything like that? Anybody have an idea?
Not CTs, but if they're steel wires, it'll knock out MRIs.
Okay. I don't know exactly. I've heard some different stories as to what they use, so I go back to see the cardiothoracic surgeon on Thursday, and that is a question I will have for him. And the meds. I've got like 17 meds over here, and it's like a challenge to go through. Well, you take this one in the morning, but another one you take it provided the heart rate is greater than 60 and the BP, or you don't take it if the heart rate is under 60 and the BP's or BP's under 100. So it's like going down through a checklist with Boolean logic. So that's fun to do, but it is doable.
Okay, well, we're with you on this one. Anybody else have any questions for Jim?
Well, just good work.
Well, actually, and with the surgeon was fantastic. I was in a ward that the guy has built on his own. He has his own ICU. He has his own step down. His office is a part of the ICU itself, and he handpicks every nurse and every person in that unit personally.
Wow.
He's an amazing guy.
Pretty good. Okay, well, thank you, Jim. Okay, last on my list is Jim Barnes.
Hi guys. Just wanted to give you guys an update on my situation. I've been through all the standard of care treatments, and additionally, I went to Europe for actinium and additional lutetium treatments, and I had completed all that in February, and then I was in Florida, so I really couldn't get a Clarify scan down there, but I came back, and last week I had my Clarify scan, and I had, unfortunately, extensive disease progression in my hips and my femurs, and my PSA has risen to about 242 and a half or something like that, 242. So that certainly isn't good news. So, in the meantime, what we're doing is, they took a liquid biopsy, and we've sent that off to Tempus as of last Tuesday. And I was calling Tempus today to bug them about it and see when I was going to get the results and how they were going to be received. And so I'm trying to stay on top of that to see if I have one of those mutations that opens up treatment opportunities. Like that Arvenus trial you guys were referring to earlier. Actually, my doc had brought that Arvenus trial up, and I had watched the video when Bob had mentioned it, and I said, "Oh, you mean the ARV 766?" And it's kind of, I took the words out of his mouth, so it was kind of funny. But anyway, that's kind of where my situation is. We're just waiting for the genomic testing to come back and see if I have any mutations that open up treatment opportunities. Other than that, I was pretty devastated to hear my PSA has risen so much, and that the Clarify scan had showed extensive disease progression in light of all the efforts and everything to get what I thought was a miracle treatment, with the actinium. So works for some folks, but not others, I suppose.
So did you do a scan and test before the actinium, before you went to Europe? So this is significant progression since then, huh?
Yes. Yeah, I had a scan done in I think September or October of last year. So yeah, that's a real bummer.
Do you keep in contact, in touch with the doctors in it was Austria, right, where you went? I mean,
yes.
Do they get these reports and stuff, and are they aware of this, or?
Yeah. Oh, yes, absolutely. I have forwarded him the. I got a disc when I left the hospital last week for the Clarify scan. I was able to upload that to a website called WeTransfer. Because it's a couple gigs size file, and he was able to download it, and he was commenting on it. and he's going to collaborate with my doc here. But in the meantime, we got the liquid biopsy. Got the liquid biopsy going with Tempest.
Okay.
Sorry to hear about that PET scan, Jim.
Yeah, me too. Yeah, I'm starting to get significant discomfort as well. In my hips and my femurs. So
What's it
Oh,
feel like? A dull ache in the background or what?
it's pretty pronounced. Kind of a sharp pain in my hip. I've actually 15 years ago I had my right hip replaced, and this morning it was the right hip that was hurting. But it seems to be sometimes it'll be in one area temporarily and then moves to another area, in my hips and my femur and my back. So just have random episodes of pain.
Yeah, damn.
Do you take something to manage the pain at this point?
Yeah, I'm taking oxycodone. At this point, if I get
so
addicted, who cares?
again, Jim, I think the discussion should definitely be around the ARV 766.
Yeah, if
And I
I have
base
those
that,
mutations, right?
what's that?
If I have those mutations.
Right. If you have any of those mutations, the mutations are a bit hard to track down. So I'll send you an image that we got from our Venus, because the trial as it stands on clinicaltrials.gov has never been updated. And so it doesn't refer to the mutations that they require. But there are 3 or 4 mutations that they do require, and they were listed in a paper, that they were mentioned in a paper, but they weren't fully listed. And we can only get to the abstract. We can't get to the actual paper. And I'll send you the abstract and I'll send you the paper. And then when we wrote to our Venus, because we needed to check, one of them is ART878A, and one of our guys had 878S, and it turned out that that A and S should have been listed and they weren't. So, we're sort of getting into the weeds, but all I'm saying is your docs need to be absolutely on top of this most recent version of the ARV trial, because they don't find it if they look on clinicaltrials.gov. And we have a direct line into our Venus because they've asked us to help them recruit when they expand the trial later on in the year, and they're going to do a webinar for us on this and other degraders, because they have a couple of other degraders now. How effective the degraders are, I'm not sure, and I think a lot of that depends on how far your disease has morphed. Because if your disease is no longer hormone sensitive, and it's acting more like a small cell disease, then the androgen receptors treating the androgen receptors isn't going to make a whole bunch of difference. So we have to make that, your medical team has to make that judgment and assessment as to whether you're going to respond where you are right now. The other thing is these harpoon trials that Len and I were discussing with Les, and there are a couple of numbers there. This DLL3 trial would be great if you produce DLL3, and you could probably. My feeling is, from what you've said, that you might be a good candidate for the DLL3 trials, and this HPN 328 is the drug they're testing. Whether Appelman is going to be on top of that or not, I don't know. I doubt that your guy in Austria is, but you know, as we've said to you before, it may be that you want, whilst you're still relatively fit, to run out and see one of these docs that has really good expertise in late stage disease. And you know, we would say either Misha Beltran at Dana-Farber or Rahul Agarwal at UCSF.
Okay. Yeah, I'm willing to travel and talk to anybody who can solve the puzzle. And incidentally, Appelman knows Gainesman, Dr. Bob's doc, in Philadelphia. They used to work together. I think Gainesman used to actually work in Pittsburgh with Appelman, and Appelman also worked with Sartor at Dana-Farber. So you know, he's definitely got the pedigree. And he seemed on top on these trials, especially the ARV 766. So he's the one who brought that up as a possibility. So
yeah, but you see what he's not bringing up as a possibility, and he wasn't bringing them up earlier, is trials for morph disease. He's not looking for that morph disease. I mean, the problem with the morph disease is it doesn't present itself. It doesn't say, "Hey, I'm here. I'm morphed. Now treat me." It just sort of creeps up, and the doctors don't look for it. That's what happened with Herbie, God rest his soul. And it was there, and some of his symptoms were obvious to people who treat this type of disease, like Dr. Munster. She said, look, if he would have presented to me the way he did, and he was having trouble getting up, and he was having pain here, and he was having pain, she said, I would have known immediately he's got the morph disease. But the GU medoncs, they're not attuned to that. They're attuned to hormonal driven disease. And then they don't go out looking for it. They're looking for what they know. So when you go to a GU medonc like Misha Beltran or Rahul Agarwal or some of those others that are really in that field, they are looking for a change in the disease before it's so obvious that we can't treat it. We got a guy, young guy, he doesn't come into this group, but we've got a young guy, he's 58. He's been dealing with the disease since he was 49 and lives in DC. And his disease has morphed, and we've been telling him forever and a day, your disease is morphing, your disease is morphing. Finally, we got him to go to Misha, and she said, it's too late, I can't take you into the trial, you're too advanced. So we don't want that to happen. You know, I swore when I saw what happened to this person, I said, I'm not going to let one of my guys who's in here, I'm not going to let them get into the state that Herbie got into without doing all of the work. And that's why we push this so hard. We may be wrong. You may not show DLL3. But if you do, we can get you into a trial which is having some amazing results. So, you know, Ben Nathanson sees Misha Beltran not because he has morph disease. That's somehow or other he's gotten there. I think he had something else that she was expertise on. So Ben sees Misha. We know Misha. I know Misha. She's lovely. And we've sent other people to her. They really like her, and she's probably closer to you than flying out to the East Coast, to the West Coast. But you just need to let me know, and then you know we can get something going. Or talk to Appelman and tell him and say to Appelman, I want you to look for morph disease. I want you to look for small cell NEC disease.
Isn't that what the Tempest genomic testing is?
Not really. What the Tempest is going to do is it's going to tell you if you have any mutations. and some mutations, but I get lost here. Len may be able to help out, but some of these mutations are definitely more common or seen in NEC, but not always. We can't see the NEC disease. We don't have any really good markers for the NEC disease. And right now, the markers we do have are in trial. So chromogranin A is a good marker. He could test you for chromogranin A. That is definitely a good marker. They could do a dotatate scan on you, but dotatate doesn't show up well in prostate cancer, even though it marks this morph disease. That's one of the problems. Len, I mean, what do you have to say on this issue?
Well, yeah, you're right. Chromogranin A can be picked up. Something we recently exchanged in emails, CEA could be a marker for NEC. But I don't believe DLL3 is going to be picked up in a
No.
genetic test, and it's not a routine blood test. It's some sort of, only certain labs, I guess, actually do it. I don't know
Right.
which ones. Yeah, but the doctors should know.
It's real. DLL3 is not a commercial test right now because we've looked into that before. I mean, I know that all these centers that are running these trials are running the DLL3 test. So like Sloan Kettering and Dana-Farber and UCSF, et cetera, they're all running the trials, but you can't get it. But that means that if Appelman is close with one of these docs that's doing some of this work on this harpoon work, he might be able to get it run. But it's just not easy to do right now, Jim. And I just want to push you. I want to push you to one of these docs whilst you're healthy enough, so they can be looking for this.
So Rick, it's David. Can I ask you a question? If you were in Jim's shoes, what would you do tomorrow morning?
I'd make an appointment either with Rahul or with Misha, depending on which place you prefer to go to.
What do you think,
Where are they
Jim?
located? What cities are they from, Rick?
Dr. Rahul Agarwal is in San Francisco, and Misha Beltran is in Boston.
Okay.
And we feel, I mean, may not be correct, but we feel they're the two best docs for if your disease is morphing. They are going to know, they're going to be able to treat you best. Even if this harpoon drug isn't right, they're going to know what else is going on and what to match you for.
Okay.
Oh, we've got another guy too. The guy in San Francisco. We've got a guy in San Francisco that I forget his name now.
Going to San Francisco scares the hell out of me.
What's that?
Going to San Francisco scares the hell out of me.
Go to Boston. It doesn't matter.
Yeah.
But this guy lives in San Francisco, and we got him. We got him to go to. We got him to go to see Agarwal, and he's gotten into the DLL3. He's been in the group. I can't remember how he came to us now. He's a nice guy. He's smart as well, and I could connect you to him because he'd be a good person to talk to about the trial. I just can't remember his name off the top of my head.
Okay.
But you have to let me know what you want to do. I mean, this was sort of the direction we were pushing you before you wanted to try the actinium.
Well, we were talking about genomic testing. We were talking about doing a Tempest or Foundations of Medicine, and I went for the actinium, and maybe it was a wrong decision, but I think that's my next step is wait for those results and see what deficiency or see what mutations I have, and then follow, and then but you're saying the foundations of medicine are testing Tempest genomic testing isn't gonna identify neuroendocrine, any sign of neuroendocrine, because I thought in previous discussions we said it would.
Well,
And
I
that's
don't
why,
know
what
that we
was the
said it.
importance of doing it?
I don't think we said it would. We said it would identify mutations. We didn't say it would identify small cell neuroendocrine disease.
Okay.
We never said that because it doesn't, because that's the problem. We don't have a way to identify it other than through these trials, through smart docs, through seeing it, maybe doing a biopsy and it being evident in the biopsy, because you can see it in the microscope. Under the microscope, you can see that it's changed. But actually coming up with these markers, yeah, I mean, Len is right. Test for chromogranin A and see what level that is. But it's these real top docs who are working and trying to find a solution to the small cell disease who are really the experts. And we know a couple of them. I mean, if you want to start with Appelman and lean on Appelman and say, I want somebody who's a real expert in NEC small cell. That's what I want to see. And see who he says. Who we can get you to.
My doc here and the doc over in Austria both claims they've because I bring it up all the time. How do we know I don't have small cell neuroendocrine? And they're saying we've treated it before. I've seen it before. And this just doesn't look like it's small cell neuroendocrine. That's what they tell me. So I'll lean on them harder and lean on it again. And I'd be glad to get a second or third opinion on it.
Okay.
But all this shit makes me crazy.
Okay.
That's why you got to go to Boston, Jim, to get that second opinion. You flew all the way to Austria. Get on a freaking airplane and run to Boston.
Oh yeah, I have no problem with that. Yeah, absolutely.
I mean, I'll give Misha a heads up if that's what you want to do, but it did take Aaron probably 3 weeks to get an appointment. Dana-Farber was not good at getting an appointment quickly. So it took him a while, but he also wasn't the easiest guy to work with. But, we have some people that we can use for pull at Dana-Farber if we need them. We've got a doc on our advisory board who's a GU med onc at Dana-Farber. If you run into any issues, and he's very, very responsive. And Misha knows us well. I mean, I ran up to Misha at GU ASCO in January. I ran up onto the days and said, Dr. Misha, I really have a guy I need you to see quickly. And she said, okay, have him call me next week. And it still took him 3 weeks.
Oh, yeah. I understand you have to have a lot of perseverance and persistence to get some top docs, for sure.
Yep.
And she would have seen him next week, but she was just getting through the bloody hoops at Dana-Farber to do it, Or I can call Alicia. Alicia always responds to us quickly. I can call Alicia and say, Alicia, please, can we lean on somebody to get it done? Or Eddie, or one of them.
Appelman should have connections up there because he worked out there for several years.
Then, tell him you want an appointment with Misha Beltran. Beltran, Misha Beltran.
I will do that.
Jim, did any of your genomic testing bring up TP53 or RB1? They can often be raised red flags about neuroendocrine.
Okay, I don't have the results from the genomic testing yet. The last testing I had was a couple years ago, and that was through Foundations of Medicine. They just took the blood biopsy last Tuesday, and it's being processed. Hopefully, we receive that at the end of this week or beginning of next week.
Yeah. Yeah, I mean, the reason that the TP53 and RB1 raise red flags is because those are signals of pretty serious disease that advances quickly. And that's why we see it in the neuroendocrine. It isn't that causes the neuroendocrine, but it's associated with it because it's associated with a bad prognosis. But not for everybody. There are guys in this group who have TP53. Dr. John, he's left. Dr. John has TP53. So it's not across the board, you know?
Right.
Hey,
Okay.
Jim. Hey,
Thank you.
Jim, I know I'm pushing here, but I'm just curious and I happen to care about you. What are you afraid of in San Francisco? If you can get an appointment there quickly, why wouldn't you just go there?
I mean, everything you see on the news. I don't know. Is it safe to walk down the streets in San Francisco? I don't even, from what I see, it's not. There's a bunch of junkies out there ready to stab you with HIV infected needle or something. I don't know.
Stay in a hotel and take Uber. Stay in a hotel and take Uber. You don't have to walk the streets. It's actually not as bad as the news points out.
Yeah. Turn off Fox News.
I don't watch Fox News, but
it's even up. It's even up. If you see Rahul or you see Misha, they're both as good as each other. If we can help you in both directions, because both those people know us, and if Appleman can get you in to see Misha quickly, that's fine. If not, we'll pull the strings. But I just feel like we need them to be looking for more than there is and rule it out. God willing, you don't have it. Yeah. And then we can go back. But we really want them to rule it out.
I do too. Although I understand it's rare.
Well, it's not as rare as we thought because the disease changes at the back end. But if you look at the results on this Harpoon trial, they've been amazing. Over 50% of the people, they've got a small sample of like 18 or 20, but half of them responded to this drug. And so, but we also know that the opportunity to treat the disease when it's morphing is a short window. So you've got to get in when it's happening, because if you wait too long, you get into the Aaron situation, where it's gone to his brain and it's too late and they won't put him into the trial because it's in his brain and this, that, and the other. We don't want that with you, Jim.
No, I don't want that.
Okay, well, you've got homework to do. We're not going to get this.
You know how to find us, Jim.
Yes. Thank you so much, guys.
Okay. Yeah, we care about you. We care about Les. I mean, this is not an easy road to hoe at this point.
I want to say one thing. I want to say one thing to Jim Barnes about, San Francisco. Look, if it's closer for you to get some treatment than the treatment if it's closer for you to get the treatment that you need, you're not walking into the zombie apocalypse. Go get the treatment. It's not good. You're not. You're going to be okay. You're going to be safe. So don't take that. Don't take that energy in there with you. You're not hanging out on the corners. You're not doing this. You're going to get treatment. It's not the zombie apocalypse. I've been in many cities and I haven't seen it yet. Okay, please.
Thanks, Eric.
Hey, Eric. If you play your cards right, you could go alongside. You could get him to take you out to San Francisco with you as his bodyguard. What do you think?
Absolutely.
Okay, guys, we're at the end of our time.
Thank you, guys.
I think we covered everybody. David Muslin, you came in late, but anybody else have any burning things they got to say before we depart?
I do want to ask Len a very quick question, because it was driving me nuts yesterday. Dr. Mark Perlow was in our group last night. He didn't come in today. And he is very concerned that he may have disease progression without it showing up on his PSA. didn't we have a long discussion about that, or a couple of discussions about that in this group? I need a memory jog here.
Yeah, we certainly did. I don't think Mark Perlow was part of our group when we had those discussions. I haven't seen him in this group in a long time.
He's in the low and intermediate every 2 weeks.
Right. And
yeah, sure. We've
jog
had
my memory, please, Len.
Yeah, well, there are some people, like I think, what's his name, Armstrong, Duke.
Yeah.
Yeah, he believes that if, guys with advanced prostate cancer who haven't had, who are still very low PSA, should be tested with CT, MRI, some metabolic scans, choline, PSMA, whatever. Well, not PSMA, because what he believes is that, the cancer stops producing PSA and PSMA, and so they should be screened or scanned with other techniques that can find lesions, even though there's no PSA and no PSMA. And he put the number at something like 20%, and these scanning tests should be done every 3 to 6 months. I mentioned that to Dr. O about a year ago, and he was like, "Well, that seems awfully frequent. I'm not sure we need to do it that often." But because I kind of pushed it with him, he did CT and MRI and technetium bone scans with me, and they were all negative. But it's a possibility, but it's only about 15 to 20%.
Well, that was the number that Dr. Kwan quoted in the PCRI conference, and that's how this came up. That he said that 20% of men have low PSA and don't, and so you won't see progression through their PSA.
Right.
And you're saying that number came from Andrew Armstrong.
At Duke. Yeah, I can dig up the reference and email it to you.
That'd be great. Thanks a million. Thank you.
Okay.
Thank you.
And the other part of the problem is that guys are diagnosed with pretty aggressive disease because it goes along and they've never shown PSA.
Right.
Until it's too late. So how do you catch that?
Hey,
Okay.
Actually,
As the insurance company, I like to give you scans every 3 months. They're going to delay.
Right.
Yeah.
Okay.
I have a guy in my Danbury US2 group, 48 years old, de novo neuroendocrine disease. Maybe I should, he's only 48. Maybe I should bring him into this group or the under 60. I don't know who's moderating under 60.
Well, I am sort of right now because in the absence of everybody else, but I definitely think you should bring him in, and I definitely think you should direct him to Misha Beltran.
Yeah, I mean, he's being treated at Smilo Cancer Center in Yale, so he's on, Firmagon, docetaxel, carboplatin. They're treating it aggressively.
Well, he may be a candidate for the DLL3 trial. I would send him up to Misha for a second opinion.
Yeah. Yeah, I'll do that. We only meet once a month, so I'll send him over to your group.
Okay. Goodbye.
Okay.
Good night, everybody.
Good night,
Thanks,
everybody.
Bye. 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 Thank you.